Hello, everyone, and thank you for joining today's Optum Rx webinar, Preparing for the Future, Pharmacy Innovation in 2025. My name is Heather, and I'll be your host. At the bottom of your webinar screen are multiple application widgets that you can use to customize your viewing experience of the speakers and slides. You can expand your slide area by clicking on the Maximize icon on the top right or by dragging the bottom right corner of the slide window. Questions can be submitted in the chat. If we do not get to all questions today, your question will be followed up through your account manager by email. Additional resources, articles, and links to related topics can be found in the Additional Resource widget. We also have a widget that you can use at any time to fill out a survey during the presentation to give us feedback. You will receive an email with a link to the recording in the next 24 hours. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. And with that, I would like to introduce Oron Stenesh and Sid Sahni.
Awesome. Thanks, Heather. Hi, everybody. Oron Stenesh. I lead product commercialization here at Optum Rx in our strategy and product team, and also focus on product development in the GLP space, health conditions, and otherwise. So excited to talk to you about a lot of the cool innovation happening within our shop. Sid?
Thank you, Ron, and always appreciate your partnership. Hello, everyone. I am Sid Sahni. I lead the strategy and innovation functions at Optum Rx. So my team spend all of our time thinking about what's next, what's around the corner. And this is a topic that is especially close to my heart. So really looking forward to talking about innovation as we go through the next 45 minutes. With that, why don't we go ahead and get started? And I'll start with the simple fact that pharmacy is in the news every day. For those of us that are inside the industry, we see it. But even if you are a common everyday American, there is no escaping the fact that there is advertising now related to GLP-1s on the Super Bowl. There is news about pharmacies shutting down. There is news about cell and gene therapies being expensive. And then just generally the perception that cost of medications continue to go up and continue to go up at an unsustainable pace. And so this is something that is deeply felt by everyday Americans today. And this is something that we keep close to our heart as we go through our solution set. Part of what we also see in the landscape is the federal and state legislative environment. As most of us may be aware, there is activity in Washington, D.C. as it relates to transparency, as it relates to delinking, and sometimes even associated with separation of the PBM and the pharmacies. What may go under the radar at times is all of the state level activity. Here you see states that have introduced legislation related to pharmacies. And over 1,000 of them across the 50 states are being essentially debated today. And that's something that we keep a close eye on. Some of the states are a little bit targeted, while others have what we call kitchen sink bills. So Illinois, Indiana, Wisconsin have everything in it in order to help regulate the industry. And this matters. This matters not only to us, but it matters to you and your clients, where flexibility and choices may be taken away. So it's something that we keep a close eye on, and it helps shape our agenda. But amidst all of this, it becomes even more important to help parse out what the signal is from the noise. If we look 3 to 5 years out, what do we see? How do we see the industry shaping up? That will actually direct the investments and the energies directed to it. And so our contention is that there are 4 key forces that are shaping the pharmacy market. These are the advancement of medical science, the ongoing focus on affordability, the expanded role of the pharmacist, and rising consumer expectations. Now, as Yogi Berra once said, prediction is hard, especially when it's about the future. And here we are actually to do the hard work for you. We think these are the key trends that will sustain us as the current dust settles and the new dust storms get cooked up. So this is what we keep as our focus as we go forward. Now, some of you may have joined us last year, may have joined us in other forums, and may have noticed that these are consistent themes that we carry over. And that's by design. If we were to come to you every year with 3 to 5 year trends that have dramatically changed, that's a problem. So we are actually pleased with the consistency and the sustainability of the trends that we have put a stake in the ground on that continue to carry us forward. That doesn't mean, however, that the world isn't changing. So let's cover each of these briefly. First, let's talk about the advancement of medical science. So historically, a lot of this focus has been on cell and gene therapies and how expensive they could be. What we've discovered over the last 12 to 18 months is that that pipeline is a lot slower than we had anticipated. Making up for that, however, is the GLP-1s or the weight loss drugs. That trend has been significantly higher than had been forecasted and is now expected to be anywhere in the $10 to $40 billion range in the coming year. So there is a significant shift in terms of how we want to think about innovation, how we want to think about all of the new drug discovery that could come through, and how we then want to make that accessible to our members, to our clients, and to every patient that should need it. The flip side of advancement of medical science is then the focus on affordability. How do you ensure access, but also ensure that can actually be something that people can afford? And this is an area that has essentially the legislative map that I had shown earlier taking shape, where legislators are very acutely focused on what members are having to pay. And certainly something that is top of mind for all of them. We are actually very proud, several of you may know, that UHG announced that as part of this and in support of transparency, we are committed to passing through 100% of rebates by the year 2028. This is a bold move on our part and an industry-leading and industry-changing move that we have decided to make. And this is in keeping with ensuring that all of the hard work we do in negotiating with pharma makes it to our clients and ultimately, hopefully, to our members. By the way, we already passed along 98%, and we're going the one step forward to get to 100% in the interest of leading the industry on this front. The next piece of this is around the expanded role of the pharmacist. We all know that the role of the pharmacist has gone well beyond counting of pills to actually provide counseling, to going to test and treat in several states. The interesting development that we see actually over the next 3 to 5 years here is the introduction of AI. We see the role of the pharmacist changing even more, where AI can actually take over some of the more mundane tasks, some of the more common tasks that pharmacists perform today, and let them be free to actually spend time on patient counseling, on patient interaction, being part of care teams that can actually drive to cures and actually drive to better health outcomes over the life of the patient. So this is an area that we are actually keenly watching that I'm not sure people appreciate as much, but we actually hope to see an expansion of this as the years go forward. And then last but not least is rising consumer expectations. This is an area where the healthcare industry as a whole has a lot of ground to make up. Today, healthcare experiences do not match what consumers experience in every other part of their life. And those standards are getting raised every day too. And so what we have to make sure is whether it's a digital experience, whether it's an analog experience, whether it's accessibility, that consumers can get what they need when they need it. And we have made significant strides but we all know that there is a gap here. We all know that there is still a long way to go before we can get to where we want to be. So if you take kind of these 4 trends that we believe will sustain us over the next 3 to 5 years, what matters then is what we are doing about it. How are we now innovating? How are we addressing the trends that we foresee? And our innovation is focused on 5 key areas that you see across the top of the screen. The first is around improving consumer affordability and experience. The second is around controlling specialty drug costs, which continue to be a significant challenge for payers. The third, and at the core of this, is transforming pharmacy benefit management, the very crux of what we do. The fourth one is around total cost of care, extending beyond just the pharmacy to take into account medical costs and what impact it may have downstream. And the fifth and final one, the emerging frontiers, is the shiny stuff. This is the cool stuff. This is the stuff that we all like to get excited about. And for sure, we do here as well. But our approach is to ensure that we are being methodical, we're being deliberate, and we're being conscious on bringing the right kind of innovation to our clients. And therefore, the broad focus that spreads across these 5 areas is what really matters. Now, at any given time, we have between 40 and 50 ideas that are going through our development pipeline. Not all will make it through, but our commitment to our clients, to our consumers, to our members, is that the ones that matter do. The ones that matter will. And what you see in the middle of the page is a sample. These are examples of 10 items that we believe highlight some of the innovation we're bringing to market, but we're happy to talk about any that would exist in our pipeline. So with that, we will focus today on 6 of these. And these are the 6 that are highlighted. Oron will talk about Price Edge, Weight Engage, and Integrated Oncology. And then I'll come back and talk about Benefit Central, Pre-Check Prior Authorization, and AI. So with that, Oron, I'll let you take it away.
Awesome. Thanks, Sid. So starting with Price Edge, many of you know about Price Edge, and I thought I'd spend a minute just sharing some of the why behind Price Edge and why we're so focused here. I actually saw a question in the chat, is Price Edge Optum's answer to GoodRx? And yes, it is, or at least it's a strong part of our answer. So it's commonplace these days for consumers to compare medication costs between their benefit and discount programs when they're buying generic drugs. So an estimated 2 to 3% of scripts are filled through the discount card channel. Why is this? It's due to a rise in plan-sponsored high-deductible health plans. So members are carrying a heavier weight of the cost of drugs. Shopping behaviors are evolving and changing. Prescribers and pharmacists are driving decision-making in new ways. And there's a ton of awareness of different cash programs and price points in the market. So when members go to the cash market and find lower medication prices, it can cause them to question the value of their benefit. And that's really the problem that we've been trying to solve with Price Edge. When we looked at our data, in the aggregate, our PBM drives significant cost savings across drug classes and across a plan sponsor's basket of drugs. But on any given drug, on any given day, at any given pharmacy, an individual member may find a cheaper price off the benefit through a discount card program like GoodRx, like Single Care, or at a retailer like Walmart or Amazon Pharmacy. And to solve those edge cases, we've built functionality to compare available cash market pricing to the members on benefit cost share and automatically give them the best price. So I think you might be familiar here, but a super quick refresher. We've developed this Price Edge or cash-informed price. It's built up by Optum Perks, our owned discount card company, and publicly available data from GoodRx, Mark Cuban, and others. And we compare that Price Edge price to the members on benefit cost share. If it's lower, it adjudicates as an on-benefit claim, applying to accumulators, deductibles, out-of-pocket max, and so forth. So 3 big things to note with Price Edge. It's all about the lowest net cost for members and affordability, eliminating the need for them to shop the cash market because we're doing it for them automatically. A second thing is data. So a big problem when folks shop the cash market is we lose visibility to claims. So with Price Edge, we keep visibility to the claim. That applies to clinical programs, safety edits, and so forth. It's good for our members, good for our clients. And from a financial perspective, our clients are kept whole. It plays within existing guarantee structures at no additional cost. So we're really excited about Price Edge. It launched in 2023, and it's had a great first 2 years in the market. We now have over 13 million lives on the product, and we're excited to continue to evolve it and to enhance the offering as we move forward. And so I wanted to share kind of one snapshot into how we're thinking about that. When we look at some of the competitive offerings in the market, particularly Mark Cuban Cost Plus, and what we're hearing from clients in terms of what they're looking for, we think there's an opportunity to expand Price Edge in a couple of key ways. So we're building Price Edge Plus, which enhances Price Edge in a number of key ways. First, we're offering lower prices than the base Price Edge product at our Optum Rx home delivery pharmacy, and we're targeting 15 to 20% or so below Mark Cuban's Cost Plus drug company. Second, we're developing a choice architecture, so showing a transparent breakdown of the price with the cost, the markup, a dispense fee, and shipping. So with Price Edge, there was really limited marketing and kind of taking credit for what we were doing with members for the pricing that they see. We think this gets us a little bit further along that road and helps us compete against the Mark Cubans of the world. And then third, we're generating plan savings. So as claims move from our retail guarantees to our mail guarantees, that's a deeper discount. And so we are creating plan savings as claims shift from one of those buckets to the other. And we know that that was an interest area that we heard from clients as we launched Price Edge. Love Price Edge, but can it drive value back to the plan sponsor? So just a bit of background on the price. It's built up from the drug price, a 10% markup compared to 15% with Mark Cuban, a dispense fee of $5, and then a shipping fee that's still a work in process right now. This price is independently set by RVO Health, which owns Optum Perks, and our home delivery pharmacy. So it's only available in the mail channel. It's exclusive at home delivery pharmacy. Similar to Price Edge, these are 100% member paid claims. They're for non-specialty generics. These are on benefit, and they count toward accums and deductibles. They're included in client guarantees and included in clinical programs and client reporting. Different from Price Edge, the member actually has to take action. So Price Edge operates automatically in whatever channel the member is shopping in. Price Edge Plus requires the member to make a choice. So Price Edge Plus is displayed in the find and price tool side by side with retail pricing, and it's the member's choice whether to elect or not. If already filling at home delivery, there's no action that's required on the part of the member. The claim automatically adjudicates the lower Price Edge Plus amount if that savings opportunity is available. So we're really excited about Price Edge Plus. It's in active development here. We're targeting mid-year this year to bring it forward. So stay tuned for more as we bring this into focus. So next, I wanted to chat a bit about weight engage and GLP-1s, everyone's favorite topic, right? As you're likely aware, GLP-1s entered the market in 2010 for the treatment of diabetes. And for the last decade or so, they've increased in popularity as their efficacy in the control of blood glucose and promotion of weight loss has really been impressive. So drug manufacturers, pharma, identified an opportunity to submit for FDA approval for their respective GLP-1 molecules for an indication of obesity. And that started this kind of tidal wave that we're all in right now. So this is Novo Nordisk's Wegovy and Lilly's Zepbound that was approved at the end of 2023. So I kind of like to describe this as a confluence of four factors. One is prevalence. So 42% of American adults are eligible per the FDA label for these drugs. Another 31% are overweight. So we're talking about 75% really of American adults that could be on one of these drugs. Secondly, there's really high efficacy, right? These drugs work. Zepbound is driving over 20% weight loss. Third, a high cost, right? These aren't $6,000, $10,000 or more specialty drug costs, but this isn't a $10 statin either. And then lastly, unprecedented consumer demand driven by celebrity endorsements from the likes of Oprah and Kim Kardashian and Elon Musk. It's kind of created this unique market event, a ton of awareness, a ton of consumer demand, and a situation where we're all trying to kind of wrap our arms around what's happening, how it's changing, and what do we do with it. On this slide, I'm trying to recognize that to have a conversation on GLP-1s, we need to acknowledge the puzzle pieces that come together to help manage them effectively. So it's important to call out that you can't make a decision on a lifestyle or behavior change component required for efficacy of these medications in the long term without first understanding, do you cover or not? What are your clinical options and so forth? So our work here is really in service of expanding affordable and appropriate access with best-in-class clinical and network designs and patient management that's delivered both by us at Optum Rx as well as vetted vendor partners in the market. We're working with pharma to lower the net cost of these drugs. We're working with our clients on strategic benefit planning, delivering insights to them, flexible client strategies around formulary, around rebate. And we have flexible clinical designs and utilization management protocols that preserve the integrity of the plan benefit and ensure that the right folks are getting these drugs at the right time. Lastly, we have behavior change programs, which I'll talk about in a bit of depth. So as we transition to talking about these behavior change programs or patient support programs, I wanted to highlight a bit of the why, and that's really around their inclusion in pharma's clinical trials and what supported the great weight loss outcomes that were reported and kind of predicated the FDA's approval. So pharma had regular check-ins, dietitian support, monthly counseling sessions, increased movement to the tune of 150 plus minutes per week. They were all critical elements to the results they were able to drive and to show the FDA kind of the efficacy and the effectiveness of these drugs. In the real world, ongoing support is sometimes lacking, and that is limiting some of the outcomes that we see in the real world. Couple reasons, really, a huge one is persistence and adherence to the drug. We're seeing 30% or so of patients stop treatment in the first month, and about 58% of folks stopping the medication within 12 weeks. So we're seeing it drive quite a bit of waste, since persistency is what will lead to the outcomes that are really hoped for when folks are covering these drugs. And also, when folks aren't adherent to the drug, as shown on the right-hand side of the slide here, we're seeing folks regain weight. So 44 to 66% of members do regain some or all of the weight they lost during their usage of the medication. And that regain is really material. So some here means they regain at least 25% of the weight they lost. So higher weight loss, those outcomes that were reported in the trials, it's only achievable if the member can titrate up and tolerate the highest dose of the medication. And that really requires them to be persistent. So we're looking at these programs as a key way by which we encourage adherence to the medication. We help educate and manage side effects and really get the most bang for the buck for both our clients and our members. So I like to describe Weight Engage as kind of an umbrella brand for the set of choices and configurations that our clients have. We're partnering, like I mentioned, in strategic benefit planning to help our clients evaluate their benefit, to help manage access and drug costs. We have utilization management strategies, to FDA label and a risk stratified approach. And then we have these integrated behavior change programs that are really focused on getting the most out of these medications, sustaining weight loss, and guiding and engaging members on behavior modification, diet, exercise, and more. Clients can choose one of the 3 options at the top of the page here on the right. So we have 2 provider-guided programs. The first is Virta, which brings a responsible prescribing approach with a nutrition therapy only path for those members that are willing and interested to kind of pursue that. So it's an opportunity for medication use to be avoided with this Virta option. Calibrate is our medication-focused path. It really focuses on the appropriate prescription of the drugs by obesity management specialists, and then wraps with longitudinal care digitally over a couple of years. And then thirdly is Real Appeal Rx. This is our member support program. It is a lower touch option, so you don't need to have a specific provider prescribing the GLP-1, but you do have to have an approved prior auth. We send those approved prior auths to Real Appeal Rx. They enroll and engage members in a digital coaching platform. We, at the end of last year, added access to OnePass Select as well. So this is an awesome fitness offering where participants have access to over 20,000 gym locations, fitness centers, on-demand, live streaming, classes, and so forth. It is at no charge to a client. It's a member or consumer buy-up at a subscription package rate. So really all of these offerings are designed to deliver behavior change and help members sustain weight loss in the long term. Wanted to give just a snapshot too into some new areas that we're thinking about. So all of what I just said was for our clients that cover weight loss GLPs today, or non-diabetic GLP-1s. As we think about those clients that don't cover GLP-1s for weight loss and obesity today, we've wanted to devise something that would allow them to offer a solution for members, but maybe carry less risk and more certainty than a coverage scenario. So enter this defined contribution concept. It's a middle ground option where we're partnering with Optum Financial to essentially connect a debit card that allows for clients to fund a set monthly amount to help consumers defray the out-of-pocket costs for non-diabetic GLP-1s. We'll be requiring enrollment in a behavior change program to verify clinical eligibility, to connect members to available discounts, to hook the member up with that Optum Financial debit card, and to provide longitudinal support. And we're working with network pharmacies to ensure that debit card funds can only be used against approved NDCs and GPIs. We're super excited about this. We've gotten some great feedback and interest from clients, and wanted to call out just a couple of areas that we're focused on and working through. The behavior change program that I mentioned, we're evaluating our weight engaged vendors and others in the market and starting to establish that partnership and build together. We're calling what we're calling spending guardrails here, working with participating network pharmacies, contracting with them, ensuring that these funds can only be used for these approved NDCs on GLPs. The manufacturer savings card sign up I wanted to call out, just noting that we're working with pharma to really evaluate opportunities for novel discounts and access to their kind of cash pricing at both Novo and Lilly. And then funding limits, executing different market research around willingness to pay. So what can we advise our clients on the right amount to add to this funding pool so that members will really use it and that their costs are limited. So we're looking for pilot customers with interest. We're gearing towards a mid-year launch with this as well. A ton of dependencies that we're working through, but very excited about the potential here. So now pivoting to integrated oncology, and wanted to start with just a quick refresher on specialty drug costs. So obviously a super high area of spend, nearly 50% or so of drug spend on just 2% of the population. And there is a delineation really between drugs that are billed on the pharmacy benefit and drugs that are billed on the medical benefit. So today, self-administered drugs, orals, topicals, and others that are covered on the pharmacy benefit. These are coded by NDC. They're reimbursed at a discount off of AWP or average wholesale price, and patients secure these drugs from retail or specialty pharmacies. On the medical benefit, we've got clinically administered or provider administered injections often. There's a J code or a HCPCS code that's billed. There's a CPT code for administration, and these are reimbursed at an average sales price plus a markup. They're provided in doctors' offices and often purchased by the doctor or bought and billed, buy and bill. Roughly 40% of specialty drug costs is actually seen on the medical benefit. And that's really important because where the claim resides drives important differences in patient cost share, in reimbursement structures, in the clinical criteria, in the underlying manufacturer contract, and much more. So on the medical side, you can see on this slide, there's a real mix of where the spend is being incurred in physician offices, in infusion suites, hospital outpatient, and there's variation in cost across those sites of care. There's also a management disparity between benefits and a lack of transparency to the set of underlying costs. Oncology provides an example of how we're thinking about this pharmacy medical benefit dynamic and what we're doing to address it. So cancer is continuing to become more complex, more expensive for patients and providers. And it's one of the biggest drivers for plan sponsors at some 12% or so of total healthcare costs. Drugs account for over 50% of oncology treatment spend, and it's split actually pretty evenly across the medical and pharmacy benefit. A note on the biopharma pipeline, and Sid spoke to this broadly in terms of gene and cell therapies. A lot of novel therapies coming forward are in the oncology space. About 50% of the biopharma pipeline is in that space, and much of that is provider administered. So given the spend and member experience opportunities for patients, providers, and plan sponsors, we think this is an area that's ripe for focus. So if you're familiar with our medical specialty provider network product, MSPN, this really builds off that concept, identifying the right pharmacy network and contracting a provider network for provider administered drugs in support of a single benefit that manages the full oncology regimen. As we initially set out here, we thought an Optum specialty pharmacy exclusive network design might be appropriate, but we've been expanding the thinking to have flexibility for providers to buy and bill from the pharmacy of their choice. We're seeking pharmacies and providers in the network to be coordinated, so not having two separate programs, but really having coordination and simplicity in the experience. We're making enhancements to our specialty medical call center and leveraging Optum Specialty Pharmacy and our Optum Health Cancer Support Program consumer experience elements to lead condition support protocols, medication adherence, refill and adherence and appointment reminders, and adverse event consultations. We'd like to explore ability to sync up with plan sponsors' existing customer support. I've gotten some questions around, can this plug into a third-party oncology vendor? Yes, we're exploring that. And we're thinking through opportunities with Optum Financial to explore patient loan and financing. So, wrapping up here, we see Optum Rx as uniquely positioned to support in the oncology space across our stakeholders. Most importantly, this is a consumer-centric model. We want to optimize the member experience whenever and wherever we touch a member, given the challenges that they're already facing. And then for providers, there's value in being able to buy and bill against controlled rates that we contract. For plan sponsors, we're streamlining process, driving efficiency through management in one spot. So a holistic view of what's happening with cancer meds, all billed against the pharmacy benefit. And then we're enhancing relationships with pharma, considering data sharing around trend and outcomes. So we're moving forward here as well, looking for a pilot, looking for a payer partner to help us really refine this concept, and really excited about the opportunity. So with that, I'll turn it back to Sid for a little bit more on Benefit Central, PreCheck, Prior Auth, and AI.
Oron, thank you. Great overview. There are actually several questions in the chat, so I'll let you kind of peruse them while I cover these topics, and maybe we can come back around and make sure we can answer as many as possible. So as Oron mentioned, I'm going to cover 3 topics here in quick succession. I'll go to the first one, which is around Optum Rx Benefits Central. And there is certainly a perception out there that the way in which clients have to manage the benefits, their PBM relationship, is maybe through green screens. And I'm here to tell you that nothing can be further from the truth. We actually have developed a digital leading set of technologies that enable a client to be able to view their utilization, be able to view their forecast, and really be able to get claim level details should they choose. This doesn't mean, by the way, that the client is obligated to or needs to become an expert in the PBM. This is part of our commitment to transparency. This is part of our commitment to make it easy. And this is part of our commitment to self-service on behalf of the client that choose to engage and be able to see all of their benefit information in one place. So it's something that we're happy to do a demo about, but I wanted to sort of bring this forward because it is something that we're excited. It is something that is available to clients today and something that we want to continue to enhance as we go forward. The next topic I wanted to cover is around pre-check prior authorization. Now, we all know the news about prior authorizations over the last few months. We recognize that. We also will say and have taken the position that prior authorizations are a necessary part of helping control costs. However, what we want to make sure is that the friction that creates, the challenges that creates, those are minimized. And so today, the way the process works is the prescriber is writing a prescription. They realize that it's going to need a prior auth. They submit the paperwork to the PBM. The PBM reviews, ensures the criteria are met, and then sends it back to the provider, and then the prescription is actually ready to go forward. This is done relatively quickly, but it still takes about 8 hours or so on average. What we have done is actually implement technology working with EHRs, working with health systems to say, could the criteria that are needed to approve the prior auth already existent inside the EHR? And if so, could we automatically approve the prior authorization? And we have found that in over half the cases, that could well be the case. And what we have been able to do is reduce the prior authorization time from 8 hours to under 30 seconds. Let me say that one more time. We've been able to reduce the prior authorization timeline from 8 hours to under 30 seconds. This is automation. And this is a way in which we bring forward the ability to actually help our clients manage costs, but take friction out of the system. Take anything that we could do to help make the process smooth, both for the prescriber and for the member. This is, by the way, hard work. This goes one at a time with each health system, and we are in the process of now rolling this out across the country. But something that we're super excited about because it helps balance the responsibility we have to control costs, but also improve experience. The last item I will go to today is around AI. And this is a topic that just everybody is abuzz with. And it's an area that we are actively participating in, we're actively watching, and actively investing and working on. And I sort of classify AI into 3 broad buckets. Initially, there was predictive AI. So the ability to look at data, to look at patterns, and say, what do we think will happen in the future based on what we see in the past? And we've got solutions that actually have been leveraging that for a while now. One of them is around client trend. Could we look at not only sort of broad trend data, but look at the very unique solutions that a client, or very unique conditions that a client may have to say, this is what we believe your trend is going to be. This is what you should expect in the future. And that's leveraging predictive AI. There is leverage to help reduce fraud, waste, and abuse, because we can detect patterns where we have been able to identify that in the past and say, if we see a similar pattern, we can get ahead of it. So predictive AI is something that we have been using, and for certain use cases, is the right kind of technology to deploy to go forward. Then came generative AI. And generative AI is where you can actually create new content. So the piece of it that we are all familiar with is something like ChatGPT. And here, we're actually using this primarily around member experience. So imagine the scenario where somebody is calling in. We can leverage AI to actually predict why the person may be calling in. When the person actually gets to a representative, it pulls up the relevant documentation so that the representative doesn't have to search for it. And then after the call, the representative doesn't actually have to document because there's ambient listening, and somebody can review the notes and actually just make any corrections and hit submit. Those are the kinds of things that we're working on to ensure that we can improve the experience and the opportunities that generative AI can afford to us. And the newest sort of age of this is agentic AI. This is where AI is acting as an agent. AI is actually looking at multiple sources and helping make a decision. And so, for example, could AI look at the person's demographic data, historic data, other pieces of information available, and help make a recommendation to say, for example, is Sid a diabetic? Does Sid have diabetes? And those kinds of things is where AI is going, and we're certainly looking to see that we can leverage it appropriately. The one important point I want to end on, and this is ensuring that there is appropriate use. So UHG has taken a stand that we will not today leverage AI for clinical decisions. It is, if a clinical decision is involved, it will always be the decision a human has made before it is finalized. And that's an area that we are very deliberate about. Every use case of AI is reviewed by a board that ensures that there is fairness, that there is no bias, and that is in fact going to meet the standards. So this is a high bar we are setting for ourselves to ensure that not only can we leverage the technology, but also ensure that it has appropriate use. So that's an area that we will continue to bring to you as we go forward. But with that, let me hand it back over to Heather. We're happy to have further discussion on these or any of the topics you heard today. This is just a scratch of the surface in terms of all of the areas, all of the exciting innovations that Oron and I and the rest of our teams are frankly working on. So we look forward to the opportunity to discuss them with you further. But with that, Heather, over to you.
Actually, Sid, I'm going to jump in and just give